as applied to longevity, not just living longer, but living longer actively and healthily with a good quality of life. I think that's what we would all agree is the aim, not just years, but good years. So let's go straight into it. Robert, would you like to start? Tell us a little bit about your work with Therm Group and your view on the whole nexus of issues around longevity, which is not a simple question.
It is. Thank you very much for having me. By the way, congratulations for the 30 years. This is unbelievable in these days to have that consistency.
Well, you're aiming for 100 years.
We aim for 150 probably. So yeah, so it's we are on the way. I will keep it short because I want to have a lively discussion. It's 4 of us. I will try to offer you the framework of our thinking when we think about longevity or biohacking or well-being or whatever the word might be, where we try to summarize what this industry is at this point in time and what will become. And I think our framework of thinking is the following. There's 4 chapters that we want to achieve. One is health span, which is clear. We want to decrease the sick span. We want to have a longer health span. We want to have joy span. We want to have a life that we can enjoy. And we want to have a longer life. The 4th chapter is something, it's called immortality, which a lot of the people find to be a very interesting topic these days. And there's a lot of social media on immortality. At this point in time, we are not really very interested in that topic. And there are 2 chapters where you can put all the factors that will lead you to these outcomes. The one is to remain in Silicon Valley and AI slang, is the software and the hardware of the human body. And the second one is the environment where we are living. And a discussion about longevity starts for us about where cities evolved. And it's for us a discussion first and foremost about cities and about the urban environments where we are living. And if you look through the history of mankind, the large cities, the million people cities, were pretty much non-existent for a very long time. We had in the Roman time, the 1 million people city in Rome, but we didn't have it for a long time. And we got this large city back in 1875 in New York. We had the first time where New York reached over 1 million citizens. And that changed tremendously the way people lived, changed tremendously the environment where people were dwelling their daily life. And that influences enormously the outcomes of our healthcare system that discussed today, but also the outcomes and how we as a society come together. Cities were not built at this second stage of the larger city for human health. They were built for economical outcomes. There were large gathering of humans. They were very efficient in order to achieve an organization about economical outcomes. And in the first iteration of that, it was a gathering of blue-collar labor, for lack of a better term. Then we transferred to white-collar. And we are now exactly in that time where we try to rethink the city as a place where we are healthy, a place where we can live, a place where the first and the second space are not the most essential spaces, but what we will call today the third space becomes that. So what we do, we build large-scale infrastructures. We call it infrastructure because we think it's essential, it's urgent. It is the place where people need to be together, which is fundamental for human health. We'll discuss a little bit later about that, what the value of social engagement is between people. And also, we are living in a loneliness pandemic in these large gatherings, which is paradoxical in a way. And that has a huge outcome on health. So to keep it short, what we do is building large-scale infrastructure in downtown cores of the modern city, which is, I think at this point in time, a home for everything that will be developed from science, pharma, and really research-based, peer-reviewed medicine to what we are talking about, the fundamentals, which is being together with humans, being around water and nature, being around the social environment, and being desegregational in one single space in the downtown core of the cities. So that's what we are doing, and I'm looking forward to have a lively discussion about that.
It's interesting that for most of humanity, human history, as you say, we're predominantly rural as a species. Yeah. Now we are predominantly urban, and we're getting more urban progressively, is what you're trying to do to create something almost rural, elements of that rural village culture, but within the urban environment?
Well, our urban environments, in my view, superseded the way our physical bodies could handle the gathering, right? So when we talk about today about crowding, we consider crowding to be a bad thing per se. Nobody will say when they meet around the fire in a village 200 years ago, I don't think I will go around the fire in the small BG because it's really crowded tonight. I think I will go in a non-crowded environment tonight. Because that was a positive crowding. It was how we got together as human beings. And we are not inventing that. We had that for thousands of years. The size and the way the cities were built doesn't allow at this point in time for that to happen. So we need to rethink the entire environment of the cities before we are coming to, to the hip and shiny things. We need to solve the fundamentals.
Evelyn, where do you come at this from? More from a medical perspective?
Only from the medical perspective and maybe a little bit public health perspective. So thank you so much for having me and congratulations to the organizers. I think 30 years, you are only chronologically 30. Biologically, we would need to measure. I am sure it's significantly less. And I would just like to open saying that I'm a clinician. I am a doctor. I am the one who is actually trying to bring all of those AI, technology, medical, scientific, also public health, news, developments, progress to an actual patient. And this is one of the biggest bottlenecks. We need policies, we need governance, we need support in terms of translating healthy longevity to populations, not only to specific circles of people, but also we need a better way to bring it to the people and to scale. And so I just wanted to mention a few things. One of the things that is important is that health span or healthy longevity is not only for healthy people. It's not making somebody who is healthy better and optimal in his and her performance. It's of course one of the goals, but health span is also for people who had cancer, who have autoimmune disease, who are chronically ill on plenty of medication. So it's not only the gap between lifespan and health span, which is about 10 years as we speak, but also the threshold. How much of a health span can we help you? How much can we do to improve without breaking the point? Being one of the longevity physicians around the world where, I'm globally active, we build a healthy society of longevity medicine for doctors. I'm getting the calls when the stem cell infusion ended in a paralysis in a 30 years old, or when a hyperbaric made somebody blind because of the strokes in the occipital area. So we see that part of the hype. That's why it's very important for us to bring the credibility to the right people and to communicate and to increase the education and the literacy of health. But just from the perspective of pure economy, you've probably heard the term longevity dividend. What it basically means, and there is a very good peer review publication on that from Professor Scott, calculated that only in the US, one healthy life added to a population would urge about $38 trillion for the country. And very similar simulations have been done by McKinsey Health Institute for other countries. So it's actually probably the best investment for any economy and GDP for every country. And so right now, health span, as you can see, the examples in China, in Abu Dhabi or UAE, Saudi Arabia, where it's Singapore, where it's a national program, I think health span becomes not only a policy, but also a national competitiveness part and very futuristic way of making sure that people not only live healthier longer, but they also are active, and not even just in terms of the workforce, the entire communication about retirement and so on. It's not about that. If you are healthy, you consume. And most of this calculation for the 38 billions was actually for the consumption. So that's very important. Now, talking about AI in that case, we are really trying, for example, in our departments, the first and still, sadly, the only department of healthy longevity in a public academic hospital that we have, where we've seen in the last 3 years 2,500 patients for free, building data sets that can enable them to see their health trajectories, how they evolve over years, and what are their priorities in order to make them feel better, live better, which medication, which supplements, which lifestyle interventions, how much, and what at which point of time they should do. And that should scale to health insurances. And as your colleague mentioned before, I am very excited about one of the news that came out a week ago. AI is helping us not only in building the data, generating data, making sense out of it, creating health trajectories, but especially in bringing therapeutics into life. And this was also mentioned in our last speaker's very, very good mention that AI can help us not only to treat diseases faster by AI-generated new targets that translate to medications. It takes time, but instead of 12 years, it took 18 months to develop, for example, this one for an incurable disease of idiopathic pulmonary fibrosis where people just stop breathing at some point of time. And most of those medications right now are already in phase 2A, phase 2, so close to humans, and they target aging and disease. So hopefully also at some point of time for those who are not sick, there will be some sort of therapeutic that will help just to reduce the pace of aging that comes together with disease.
Thank you. Can I just ask you, because it was a very interesting statistic that you cited, $38 trillion, but I want to make sure we understood it. Is it one extra year of healthy life, or what's the exact statistic?
One extra healthy year of a lifespan for each of the...
In America?
That's for America only, yes.
Is $38 trillion to the economy?
It's a Nature publication. You can look it up.
Okay, thank you. Well, let's move on to Pelayo. Would you give us your perspective? Thank you.
Daniel, thank you so much for having me. It's such a great pleasure, and it's been a couple of very successful days. So I actually would like to take on what Evelyn was saying. And as we are in a government summit, why not starting with a little bit of history? Does anyone in the room know when retirement age was first introduced? So retirement age was first introduced in the second half of the 19th century by General Bismarck. At that time, life expectancy in Germany was 37 years old. Retirement age in the second half of the 19th century was 70 years old. For anyone doing the maths, actually you were supposed to die on the job. And that is something that the paradigm has shifted today. Right now, we have an aging population. As a matter of fact, in the European Union, actually the population has stopped and is expected to decline. We have an old dependency ratio that is going to double in the next 100 years. And we have a welfare state. Now, when we first started to study economics, or I think for kingdoms for the last thousands of years, they thought of people as subjects, that they were producing assets. And the more territory you could have, the more people you could hold, the more food you could grow, the more you could have armies to conquer new territory. And that, we can see it even in certain countries today around the world, they think the same way. But that only makes sense when lifespan equals health span. Today, in most European countries, life expectancy is above 80 years old. But health span is 20 years shorter, which means that while you are producing asset, or while you're a healthy individual, you're an asset for the country. When you start going into that 20 years where it's shorter of health span, you become a liability. And the current economic model is going to put such a pressure that is unfeasible going forward. So that is why it needs to be a different way. No? And actually, today, I mean, we're in the world, we're with economists, we're speaking about healthcare. And when I went to the gym this morning, there was no one. I saw one person. When then I went to the dinner, a beautiful cocktail, I saw Johnny Walker, big, 450 people lining up. And there's where you can see that it's a behavioral issue. And there's where I think we can look into it. For us, in Oakmont, we decided to take a different approach. So in a nutshell, we're looking at building the next generation longevity platform, embedded what is preventive medicine inside our clinical well-living community. So it's both the physical aspect together as well with everything that has around it. So we're building the first vertically integrated precision health ecosystem. Number one, advanced diagnostics. Number two, highly personalized health treatments. And number three, all the AI-powered intel. Now everything embedded into one ecosystem where we have the real estate and powered with luxury hospitality. All this is going to be anchored by a $450 million investment to develop our first flagship in Marbella. We started building from acquiring Incosol. Incosol was the first longevity resort where King Fahd, Lady Diana used to go for the health treatments. And from there, we're building 29 branded residences, 125 luxury suites, 15,000 square meters of clinical facilities in what is the #1 location in Marbella, side by side to new Four Seasons. Because we want not only the places where people like to live and spend time, but most important, we're also the best practitioners who like to live. Because at the end of the day, it's a talent that you are able to attract that really makes a difference.
Thank you. Well, I'm learning this vocabulary of health span, and I'm not quite sure whether I should feel happy that generally the trend is expanding it, or concerned that I'm already bang in the middle of when it should be over already. But anyway, never mind. In your what I'm sure will be wonderful ecosystem of healthy facilities, will you also sell Johnny Walker?
No.
No Johnny Walker. Will be alcohol free?
There will be several options to help you along the way. If you really fancy a whiskey, it's something that we will have a coach that will speak about it with you, but we will not sell whiskey.
Okay, all right.
But it will be very pleasurable.
You maybe just destroyed half your market, but fine.
We should check the gym tomorrow morning.
Yes.
What will happen after this talk? Probably will be 500 people in the gym.
Noah, over to you.
Yes, thank you very much also for the invitation to be here. It's fascinating to see that already like 3 people on the stage are possible users of what we are developing, because what you are describing, like our visionary founder already in the 1960s has envisioned, and now it's the time how we can actually translate it, not only by the new upcoming technologies, but make it from an idea into reality. And to address this in the best possible way, I've decided to come up by the suggestion from Robert to believe in our rural standards, and I will not speak sitting, but I will stand up, go to the podium, and will start with my opening remarks.
It's very healthy to have that.
Yes,
little walk.
that was the idea. So thanks, Robert, for the great idea. So similar as Pavelo, I thought the best way, as this is also a political sentence, is to start with that over the last days, we have heard a lot about shifting geopolitics, economic pressure, and fast technological changes. And therefore, I would like to bring this conversation to something that sits underneath all of this, the health and performance of all people. We cannot build resilient economies, innovative companies, or confident societies if large parts of the population live with preventable chronic disease. Yet, this is a direction many of our systems are taking. And therefore, it's fitting that we meet in the country that gave the world both philosophy, as in the talks before, and also the modern Olympic Games. When Pierre Coubertin relaunched the Olympic Games in Athens in 1896, he coined the phrase, mens fervida in corpore lacertoso, a fiery mind in a muscular body. He described the idea of combining a sharp mind and a capable body. And this is still a very powerful image of what good health and performance should mean today. However, our healthcare systems do not reflect this vision. We have built excellent services for heart attacks, strokes, and cancer. We have specialists, hospitals, and intensive care. But we have much weaker systems for keeping people physically and mentally fit over many decades. We only spend heavily when people are already ill. We spend far less on preventing illness and maintaining function. Chronic non-communicable diseases such as cardiovascular disease, type 2 diabetes, and neurocognitive decline take most of our health budgets. Many of these conditions are linked to risk factors that we can measure and change years before a diagnosis. The science to detect those risks exists. The tools to monitor and behavior and support the change exist as well. So the question is, why do we not use them systematically? On the innovation side, there's good news. We have advanced diagnostics, continuous biomonitoring, digital health tools, and AI. These can show small changes in physiology and cognition long before a doctor would normally see a problem. New therapies are arriving in metabolic medicine and neurology. Continuous innovation in medicine and biotechnology will remain important. But the biggest lever for revolutionizing healthcare, as this is our title, is not the next drug or any device. It's the mindset and the right incentives that need to be set. For clinicians, we need payment and career structures that reward keeping people healthy. This means outcome-oriented reimbursement, long-term relationship with patients, and time to focus on prevention, not only volume of procedures. A doctor who helps a person avoid a heart attack and delay memory decline by 10 years creates huge value. But in many systems, this value is still invisible. For all citizens, we need environments and messages that make it normal to care about health early in life and stay engaged. When people can see their own data in a very simple way, like with Whoop or Aura, and when they get support to act on it, prevention becomes real. And policymakers can support or block this important shift. This is where governments and payers are crucial. Rules for reimbursement, primary care, data use, and the adoption of proven innovative decide when these tools serve everyone, or mainly improve late-stage treatment for a few, as the system is working right now. If we want to move towards preventive and performance-oriented care, we need to improve quality of life and also compress serious illness into a much shorter period at the end of the life. That reduces long-term costs for health and social systems. And that's why I want to end. My own work has convinced me that health is a societal challenge, not a personal one. We need to think in decades, not in election cycles. Small choices, repeated over time, shape the health of citizens and therefore the strength of our countries. The body and the brain are adaptive systems. We can all train them. We should not only repair them when they fail. Therefore, for me, the Olympic ideal, as presented before, is more than sports. It reminds us all that performance and well-being must be built and they cannot be taken for granted. So therefore, in the discussion that follows, I hope we can look beyond all the technical innovations and what's possible and ask now what is practically needed to implement that. What governance, what incentives, what kind of public trust do we need to make for prevention and performance to be included as an organizing principle of healthcare? So yeah, I'm excited for the upcoming discussion. Thank you very much.
Thank you. Well, our time for discussion is going to be very short, I'm afraid, because we've overrun, and although longevity may be increasing, our conference has to end at a certain time, I'm afraid. So what I would suggest is, if you each have 1 minute to say what you think, and to pick up your last point there, Noah, what you think the most important measures to be taken over the next, let's say, 4 or 5 years to improve matters from your perspective in healthy longevity, what would they be? And let's start with you,
yes.
Moving straight on from that, because clearly you take a very broad societal approach to that.
Yes, thank you very much for the question. So like what I felt most when like talking to doctors who could apply our technologies, they were always saying like, look, Noah, like how can we get the money back? We are not like there only to serve the people, but we have to run a commercially attractive clinic. So for them, they need made by the government's catalog of how innovative therapies can be reimbursed. The last time, like in Germany, the whole reimbursement system was actualized was before I was born. More than 30 years ago, the catalog of how much is charged and for what kind of treatments was updated back then. Like the whole system set the wrong incentives. One clinic in Hamburg does more hip replacement surgeries than the whole country of Denmark. This is absurd. That has nothing to do with the benefit for the people or like who benefits from those treatments. It's just a commercial-driven mindset, and we need to come back, led by government and policymakers, from a system that treats when something is bad, up to a system that these illnesses don't even come into place or much, much later in life.
Very good.
Thank you. So I think that the issue that we're seeing, we have first a highly reactive system about disease management. And I think that the mode here is behavioral. People need to, 90% of the factors that actually affect our health happen outside of hospitals. No, and what we're trying to develop with regards to data is, I think, is the longitudinal data of our clients. Most health institutions have static data on clinical trials. We're building multi-year, multi-omic on the same individual. And I think that I want to leave a question actually to the audience. Now, let's imagine the average person is 50 years old. Now, if life expectancy is 84, he has 34 years left. 34 years is 300,000 hours that we have left to live. If 1/3 you're going to be sleeping, you have 200,000 hours left to live. Now, if we take health span, that means if that goes that same measure to around 50 to 100,000 hours you have left in the tank. So next decision when you come out, ask yourself how you want to actually live the remaining 50 to 100,000 hours and what decisions you're going to take.
Can I just ask you a quick question on that? You put the question, I think, rhetorically to the audience, but do you think, in your experience, people want to know about this? Or are there some people who would rather not know about the mapping out of the rest of their life?
Well, I think
we know with one thing for sure, we will all die. Or at least maybe we think that's for sure, but it's becoming less sure. But I think it's still pretty sure. But do people really want to know the rest of their lives?
It is childish, especially in a welfare state, to think that you don't want to know, and that the decisions that are actually impacting your life and the life of all the people around you, which are contributing to the welfare state.
So we have a responsibility to know.
You have a huge responsibility to take ownership. Why are we treating so? Health and time is the utmost luxury we have, and yet we think of it like a given by God, and we must take responsibility of our health the same way we treat, for example, our capital or decisions we do in the companies we sit in the boards.
Very good. Evelyn.
I think it's important for people also to know what to do. And one of the bottlenecks that we need to fight is to make sure that people, without going to a private clinic or to a special place, but to just their general practitioners or to a hospital or being enabled with AI, can actually know what they have to do for themselves, by themselves, and what not to do. And this can be done by, first of all, good policies that will enable education of medical students, doctors, so they can provide the information of the new therapies or the new trackers, interpret the data and say what to do. There's a lot of diagnostic places by now, but very few that can actually guide and give a protocol to patients. And AI cannot do it by itself. It can help. And secondly, the proper investment in what will actually move the needle, because one can work on habits and welfare and motivation as much as they want. For people who have already been struck by diseases, but they still want to improve their health span, they will look for therapeutics. And I think here, the new ways for us to develop and identify therapeutics and bring them to the trials is the way to go.
Robert, last word to you.
60 seconds for eternity, right? To discuss longevity. I'll use less than that. So I think we need to start seriously having a discussions about city. About cities. Yeah. I was in a conference a few weeks ago, and somebody described it very well, that the 18th century was the century of the empire, the last 100 years were the century of nation states, and we are going, because of the scale, in the century of cities. And I think in some form that's true. And we need to rethink the infrastructure of cities. We need to rethink how our life in cities really work. That's the most fundamental effect on our health from all the effects that we are talking about. Like I said, by the end of this century, probably, by this decade, probably 65% of the people who live in cities. That has to do with food, that has to do with air, that has to do with water, that has to do with all the fundamentals that affect our life. So we need to rethink infrastructure in cities. We need to rethink how we live in cities. That's, for me, the most important thing we can affect. In the absence of any AI discussion, which is very sexy these days, but probably we should start with the fundamentals.